Hello, this is Dr. Mary Grady, and if I can open this up and back up to the very beginning of this, I will do a presentation on orthopedic review. Just a few things we need to think about with musculoskeletal issues. The one thing I like to point out that there are common areas shared by all surgical ortho patients, and these are a need for lab monitoring of vital signs, drains, neurovascular checks, and exercises. And the big thing is homegoing instruction needs to start on admission to the hospital or in an outpatient area, training a person before they go home, because you don't want people coming in for in and out surgery and trying to educate someone when they are under anesthesia or not themselves. So homegoing starts when people are with it. So here's a few pages here to talk about. And one is, the first thing I said was they all have in common is blood work. Because anybody that goes to surgery has had something done. They've either had their H&H drawn or they've had a complete blood cell count. And if someone has a complete blood cell count, or a CBC, a standard CBC includes all of these things. Not only the red blood cells, but the H&H itself and the white blood cell count. Now, if you were to do this and make it a CBC with diff, it would include all of this, plus a breakdown of all the white blood cell counts, telling you about the basophils, the eosinophils, all the phils. And it also includes like your platelet count and a bunch of different things here like the MCV, MCH that we never really look at unless you work in specific hematology areas. But just to know that all of this is in there is important. So just a few little definitions here to help you. A complete blood cell count has red blood cells in them, and it's the actual number of red blood cells per volume of blood. And this is very, very important to tell how someone is doing. It also, if someone's red blood cell count is low, I know I'm going to watch them for signs of bleeding. I'm also the platelet count is something to look at, the number of platelets in a given volume of blood, because I know that if platelets are decreased, if the platelet count is decreased, the person may not have the ability to clot, or and that's important to know under certain conditions and certain things that you would do for them. Hemoglobin, the oxygen carrying protein in the blood. A hematocrit is the percentage of red blood cells in a given volume of whole blood. So that's why it's gotten to the point where a lot of doctors are just doing the H&H instead of the CBC because it's cheaper, and plus it tells you kind of like what you need to know about if there's not enough red blood cells in the body, then I know there's not going to be enough platelets, and I know there's not going to be enough other factors. So there you go. Here's some definitions in this PowerPoint that kind of tells you about those MCVs and MCHs and etc. And those are actually just measuring and looking at how big is a red blood cell, what is its hemoglobin concentration, carrying capabilities, and this would be very important to know in certain hematological conditions. If someone was hemophilic, if someone had sickle cell disease, etc. White blood cell count, you guys should all know that, is between 5 to 10,000 is normal, and the differential looks at the different types of white blood cells. Labs are being drawn pretty frequently on patients that have had surgery. It's done before surgery and at least one time while they're there, like daily. They used to draw it every 6 hours. That's why that's there, pre-op every 6 hours and then daily. But now they're starting to kind of just do it daily because it's cheaper and they're finding that it hasn't changed that much. Hemoglobin and hematocrit levels, just so you know, they vary based on whether you're male or female because it varies based on body size, basically. And also to keep in mind, hemoglobin below an 8 or a 9 usually needs the person will need a transfusion. Some doctors are starting to go even below that to 7, or wait until a person shows signs and symptoms of being very anemic or hypovolemic and needing a transfusion. But where this is important to me as a nurse is if I have a patient and their hemoglobin is an 8 or a 9 and I need to put an IV in, I know right away that I'm going to have to put like an 18-20 gauge in and not like a smaller, because I know that I may need to give blood and I want to make sure that I don't have a 24, and I want something that the diameter of that needle can take care of having those red blood cells go through. Labs are important because there's blood that's lost during surgery. There is surgical blood loss. Just to let you know, people with their knees done, they lose less blood because there's a tourniquet on. More blood is lost with hips. You can't put a tourniquet around your hip. Most of the patients that have had their hips and their knees done especially are placed on anticoagulants to prevent clots and DVTs. Also, it's very interesting that the stockings, the compression stockings that they're hooked up to at the bedside, some doctors are sending their patients home with those because they found that they stay on those for a period of several days. It helps prevent clots and DVTs as well as TED hose. You may see things like people put on Plavix, Lovenox, Coumadin. These are all heparin injections. These are all things that are done because we know that there is a chance when they go in and they fix a knee especially, or a hip, they have to go in and they have to break bones usually to put things together. And inside your bone is marrow. So you worry about clots forming. So, with all of that said, one of the things you need to remember is, do you know how to give a sub-Q injection? Because those would be fair game for me to ask on a test. Do you know your sub-Q landmarks? Do you know the angle of the injection? These are things that you need to go back and look up because you cannot forget these things as a nurse. And I know you learned them last semester. So you learned that the angle of the injection is 45 to 90, depending on the person. Sub-Q means I want to get it in fat. So if I have a very frail, skinny patient, I might want to pinch and go in at a 45-degree angle, whereas if I have someone that's got a little more adipose tissue, a 90-degree angle might be done. I also want to know that my sub-Q needles have a 5/8 inch needle on the end. So knowing my needle size for my sub-Qs and my IMs is also very, very important. And the board is starting to include that information on the NCLEX to see if people understand that. Just so you know, anticoagulants can be given IV, sub-Q, PO, many different routes. And drug doses are based on people's platelets or their INR and PT levels. Some normals here that I placed on here for you that are kind of like nice to know. What a PT time is, it's the amount of time needed to form a clot, and it's measured in seconds. So your prothrombin time is, if someone's normal, that's telling you that their blood can clot pretty efficiently. When people are on anticoagulants, we may not want them to clot normally, but take a little bit of time because we don't want that risk of a blood clot. So that's something to keep in mind. The INR stands for International Normalized Ratio, and it's this huge mathematical equation that pretty much tells you whether the anticoagulants are being effective in that person. So INRs want to be in a certain level for them to be therapeutic. Now, there are things that can change our clotting factors, our PT and INR results as well, and that would be alcohol. Alcohol can affect the PT-INR results. Antibiotics can increase them, and there's a lot of other things that can decrease them, like the meds that you're on, hormone replacement, or sometimes multivitamins that have a lot of vitamin K in it, because vitamin K is an antidote. If you're bleeding and you need to stop, vitamin K would be what you would need. My mother-in-law, her anticoagulants, when she was on Coumadin, she was bleeding quite a bit, and they had to have me give her vitamin K injections for several days so that it could kind of help clot, so that they could get her PT-INR back to a therapeutic range and not her bleeding too much. So that's something to keep in mind. Keep in mind too, if you have a vegetarian or someone that's eating lots of vitamin K, those people that love their kale and their greens and soy products, this could alter the PT. Another thing to keep in mind is all these surgical ortho patients have in common is vital signs. When people have surgery, it's very common for them to be hypotensive. A lot of it's the medications that they were given for surgery. A lot of it as well is not only that, but they go hypovolemic. You lose volume in your body. When you go to you need to take the blood pressure before you ambulate somebody to make sure that it's even in a range that's safe to get them up. Set them on the side of the bed first and let them kind of set before you stand them up to walk them. And it's very important to pay attention to those vital signs, because you're watching for bleeding, you're watching for hypovolemia and all of the things that go into that, so the person won't be hypotensive. And you're also watching vital signs because we know when you have these musculoskeletal type surgeries that there is a chance for fat embolisms. Drains is another thing to think about. A lot of these surgeries have drains that are in the body, like a JP drain, and these commonly stay in for a day or two, so 48 to 72 hours typically. Drain is pulled out by the patient for some reason. Save it for the doctor so they can look at it to make sure all the drain fell out and some didn't get left into the patient. Chart anything that comes out of a wound or anything that goes into a drainage collecting device. You want to remember COCA. You want to look at the color, odor, consistency, and amount of drainage that's coming out of anything, and that would be reported on your I&O sheet. You also want to be able to describe what your drainage looks like. And so serous is that clear kind of red drainage, and sanguineous is like a thicker red drainage. So just knowing what those words mean would be helpful when caring for these patients. Another reason you want to monitor those vital signs is you want to watch for signs of infection. Because that's always possible when you have somebody that's had a surgery done. And so you can tell that through the vital signs, you can tell that through the labs, you can tell that by looking at what's draining out of a wound. You also want to monitor the surgical site. Look for warmth, swelling, and redness at the site, because sometimes when people have appliances that have been placed in, like a hip or a knee joint, these appliances could cause an infection or a reaction in certain people, and sometimes they have to take them out and redo the surgery. I've seen people have their knees replacements taken out. They had to have a knee brace put on the whole time until they could come back and have the surgery redone. Another thing that all of these orthopedic patients have in common is you, the nurse, have to do neurovascular checks. Neurovascular checks will be something that you will be asked on a test. You do these for any orthopedic surgeries, any musculoskeletal injuries, people with cast and tractions, etc. Everyone gets checked out with neurovascular checks. We're looking at the extremity, and we're comparing the extremity that's had surgery or an injury done to the opposite side to make sure that it looks the same as the other side. So you're checking the extremity, you're looking at the color, You're looking at how it feels, the temperature, if there's a pulse, is there cap refill, is there sensation, and is there movement? Because with a cast or a surgery or traction, if any of these things were to start to change, this might be a sign that there is neurovascular damage. Maybe the damage was done from surgery. Maybe it's because of swelling in the area, pressing on nerves. Maybe it's a cast that's too tight. Whatever it is, these are things you need to look at. And if there's changes in these areas, you need to let somebody know. You need to call the physician. I put a few little things in here about certain surgeries that you can go back and look at, about the shoulder cuff. There's a lot of shoulders being done. And so I put a lot of information in there for you to look at, so you can kind of see how they would test for that. I put in there an ultra sling, which is something that you see used quite a bit with shoulder surgeries, and a shirt needs to go underneath that sling. I put something in there about Marcaine pumps, or pumps that, little things that they use where they put into tissue to kind of help with the pain in that area. Big thing about it, have you ever seen anybody with a pump with these tiny, tiny little tubes that look like dental floss? You can't put ice on top of those tubes because it'll freeze them up. One thing with orthopedic surgeries, you see a lot of ice being used as well. You see exercise, so I put a few exercises in there to think about. I put some information about the knee in the PowerPoint for you to look at. Knee surgeries could be everything from ligaments being repaired to just maybe the meniscus, just the pad between the knee has, there's bone to bone, and there just needs to be a new pad put in there. Exercises that need to be done. The big thing about knees is you'll see a CPM, or a continuous passive motion machine being used, where they may put someone on this for 12 hours a day, where you put the leg in this machine and you turn it on, and it just moves it back and forth very slowly. The big thing is there's an on and off switch, or a cord for this, like a remote, that you need to make sure that the patient has, just in case the machine were to go crazy, then you know they can call the physician. Just to let you know that with knees, if there is anything like foot drop that occurs, or a burning pain or calf pain, these could be all signs and symptoms of neurovascular issues or a blood clot. And with a knee, these need to be reported to the physician immediately. The one thing about knees are, you can go in and you can do knee surgery where they do orthoscopic work, and they just go in and they remove different parts of things, tissue, arthritic areas, and it's not a replacement. And these extremities might be placed up on a pillow to promote, to reduce edema to the area. But then you have a knee replacement where they've went in and they've actually put an appliance for a totally different reason. These would be the folks that you would not want to put a pillow under a post-op knee if the person has had a knee replacement, where they've went in and put like one of the prosthetic joints. Hip replacements, there's just a few information about those, telling you that no flexion of the hips greater than 90 degrees. These patients are told not to cross their legs or ankles, and they may have pillows that are put between their legs to keep their legs at a wide angle, or they may use a wedge like the one in that picture to kind of help keep the legs where they need to be for healing. Log rolling for backs is what I wanted to say. Backs, when you're doing neurovascular checks, all of a sudden it becomes very important to not just look at one extremity but all four, because you have a spinal cord that goes all the way down, and if a back is operated on, there could be damage done to something where you could see neurological deficits in any of the four extremities. Complications from any of the ortho-related surgeries could be hemorrhage. It could be the neuromuscular dysfunction, blood clots, pulmonary complications. All surgical patients need to have those incentive spirometers used, because when you have surgery, you have atelectasis, and you need to be able to use the incentive spirometer to cause those little flattened alveoli to start to inflate again so that you do not get pneumonia. And there's always a possibility of a pressure ulcer, especially if you have a brace, a cast, a sling, or something that's not fitting very well, or people are not positioning you very well. You could get skin breakdown. So just a few other little things that we want to keep in mind is on this list, but I would like to say that we want to include teaching for that patient and their family so that people know what's expected of them. Nursing diagnosis, there's many. I just listed a few. You could come up with more. Pain's the big one. Impaired physical mobility, we have to use a lot of assistive devices and braces and cast and traction and all kinds of things with orthopedic related surgeries and injuries. There's skin integrity issues. There's also a risk for impaired urinary elimination because people don't like to get up and move around because it hurts too much to go to the bathroom. You worry about the people having constipation as well from not being as active, and ineffective coping. With the assistive devices, there's a few things I would just like to point out here. I would like to talk about walkers, and how do you know a walker is a good fit? Well, you have the person stand with their arms relaxed at both sides. And when they stand like that, I think I just passed by what I wanted to be on. You want the top of the walker hand grips at the patient's wrist level. So when you stand anatomically, your wrist should be right there where the hand grips are on your walker, so that when you put your hands on the walker, you have a nice bend to the arm. You have a 30-degree bend. And that way it's enough that you're not like straight out or crunched over too much. It's like a good, so that you can pick up the walker and place one foot ahead. Usually the affected leg goes first. You push down on the hand grips and then you bring the unaffected leg. So you always move the walker, press down with the arms, bad leg first, followed by the good leg, if that is the purpose of what we're using it for. A few tips to talk about the walker besides that I would want to point out is when people are trying to get up with a walker, teaching people not to use the walker as something they pull on to pull themselves up, because it's not going to work that way. And just always when you use a walker and you stand up, stand for just a few minutes to stabilize your balance, your blood pressure, and everything else before you take off. Canes, another thing I'd like to talk about canes is you figure out if a cane is a good fit the same way you would with a walker. You have a patient stand in the anatomical position with their hands relaxed at their side, and the height of the cane, the top of the cane should be right at the wrist level of the client. The thing with canes, a cane should move with the affected leg. So you want to make sure that the cane is held in the hand that is opposite of the affected leg or the affected arm, because you need a good arm to be able to maneuver that cane and put the pressure on it as you're walking. Crutches, the thing I would like to point out with crutches is you will see people using them with a 2-point, 3-point, and a 4-point gait 2-point looks like you're walking. You're just moving a crutch and an arm at the same time. A 3-point is what you see most kids that have broke their legs, where they have one leg on the ground, one is kind of bent, dangling in the air. So you've got the 2 crutches and one leg on the ground. That's 3-point. And 4-point is the one where it looks like there's always something moving, like one cane, one leg, one cane, one leg. So it's kind of in that nature. The big thing about canes, you want the arm bend 15 to 30 degrees. So you want the person to stand with their cane, with their crutches by them. You want to be able to put 2 to 3 fingers from the top of the crutch to under the armpit to make sure that it's not just shoved up in there and there's enough room there to move around. And then you want them to stand anatomically, and the hand grips where the hands go on the crutches should be right at the wrist level on the patient. Now on the walker, the cane, and the crutch, all of these have, all these assistive devices have things on them that allow you to regulate and make that crutch or that cane or that walker fit the person that's using it. Just remember that tips get wet, especially when it's wet outside, and sometimes if it's in the middle of winter, our patients need to be reminded that things may need to be cleaned off when they come into an area, especially coming out from outside when the snow's on the ground to a tile area. You could fall real easily. So that concludes the end of this orthopedic slideshow on orthopedic surgeries. I hope this little overview was helpful and kind of giving you a little something to study with and to think about when you look at this. Okay, take care.